Good evening, sir.
Good evening.
Hello, good evening.
Good evening, sir.
Good evening.
Sir, ಯಾವಾಗ ನೋಡಿದ್ರು ನೀವು ಕಾರಲ್ಲೇ ಟ್ರಾವೆಲ್ ಮಾಡ್ತಾ ಇರ್ತೀರಾ ಪಾಪ. ಆದ್ರೂ ಏನು ಕೋಟ್ ಗೀಟ್ ಎಲ್ಲ ಹಾಕೊಂಡಿದ್ದೀರಾ, ಏನು ಎಲೆಕ್ಷನ್ ನಿಂತಂಗಿದೆ?
ಇಲ್ಲ ಇಲ್ಲ, ಈಗ ಯಾವ ಎಲೆಕ್ಷನ್ ಇಲ್ಲ.
You can actually log in now and try your uploading. You have the link, right? Thank you. Okay, yeah. ಟ್ರಾವೆಲ್ ಮಾಡ್ತಾ ಇದ್ದೀರಾ?
ಇಲ್ಲ, ಸ್ಟಾಪ್ ಮಾಡಿದ್ದೇನೆ.
ಹಾ.
ಸ್ಟಾಪ್ ಎಟ್ ಎ ಪರ್ಟಿಕ್ಯುಲರ್ ಪ್ಲೇಸ್.
ಎಲ್ಲಿ, ಕೊಪ್ಪಳದಿಂದ ಎಲ್ಲಿಗೆ, ಬ್ಯಾಂಗ್ಳೂರಿಗೆ ಹೋಗ್ತಾ ಇದ್ದೀರಾ ಹೇಗೆ?
ಹಾನ್ಗಲ್, ಟುವರ್ಡ್ಸ್ ಹಾನ್ಗಲ್.
Okay.
From Shigaon to Hangal.
Okay. MG sir.
Sir, Bharti is in an emergency. Madam will join late.
Bharti is always in emergency whenever there is a webinar. I don't know why. Good evening, sir. Hiremat sir, good evening. Looking very smart.
Good evening.
Good evening, sir.
Everybody, good evening, Murli.
Good evening, sir.
Good evening, Sajjan.
Yes, sir. Good evening.
Yes, sir.
You are in Sikkim or where are you now, Murli?
Sikkim.
What is the temperature?
ಈಗ ಸಂಜೆ ಹೊತ್ತು 4-5 ಇರುತ್ತೆ.
Oh my God.
Day time it is 12 to 16 ವೇರಿ ಆಗುತ್ತೆ.
Snow falling?
ಸ್ನೋಫಾಲ್ ಗ್ಯಾಂಗ್ಟಾಕ್ ಅಲ್ಲಿ ಇಲ್ಲ, ಸ್ವಲ್ಪ ನಾರ್ತ್ ಇದೆ.
Okay.
ನಮ್ಮ ಇದರಲ್ಲಿ ಸುತ್ತಮುತ್ತಲು ಇಲ್ಲ. ಮತ್ತೆ ಈಗ ಇವತ್ತು ಏನಾಯ್ತು ಸುಪ್ರೀಂ ಕೋರ್ಟ್ ಇದು ಡಿಸಿಷನ್? ರಿಸರ್ವ್ಡ್ ಅಲ್ಲ?
Reserved. Judgment ಆಗಿಲ್ಲ. They have heard.
ಬಟ್ ಈಗ ಯಾವಾಗ ಜಜ್ಮೆಂಟ್ ಆಗುತ್ತೆ?
In a day or two there will be judgment.
Okay.
There is no more hearing.
Yeah. Oh, no more hearing. Okay. So and after that they will announce counseling.
Both for PG and UG. Counseling will start. It will get late. UG, I think it may go to March.
Howda?
But by the time they have to do so much of UG, you know.
Alla, first PG na, amel UG na, hege?
First PG. Because of the COVID, they are badly in need of doctors in the hospital. Most of the hospital, more 50% of the doctors have gone out. And now
that was a wrong advice given by you know who gave it. I don't want to take the name.
Third wave is on.
It was a wrong advice given that you postpone the everything. You will get at the actually if avaga mugsbitididre.
See, every time you see first wave came in the December, January. Second wave came in December, January. This third wave also December, January in India. Lucky that our Davangere conference is more.
ACOG postpone aitala.
Without a single casualty. Nobody got COVID in Davangere.
Illa. Punyaka adondu olledaytu.
Chinmay is joining.
Yes.
There she is. Chinmay, you are fine. Your voice was little bit down.
So yesterday I tested RT-PCR positive.
Oh, that is why I think.
Yes,
you are
sir.
okay. You can give it, no?
Yes, sir. Yes, sir. Absolutely, no problem.
No cough or anything in between.
Good evening, madam.
Good evening, madam.
Good evening, sir. Good evening.
Good evening. So that's great. With RT-PCR positive and you are on.
Yeah, that shows the commitment. Anyway, we are not going to announce that.
No, sir.
It is only off the record.
Yeah.
Yes, sir.
This 15 minutes is only for faculty to discuss.
That's what.
All good evening, all. Good evening.
Hello.
Good evening, Manjula.
Good evening.
Manjula has become Rahul.
Opening.
Okay, change ಮಾಡ್ತೇನೆ.
Rahul Patil. Oh, I thought Rahul tara opening batsman tara anta.
ಇಲ್ಲ. ನನ್ ಮಗಂದು ಟ್ಯಾಬ್ ಇದು.
Oh, okay. That's why.
ಚೇಂಜ್ ಮಾಡ್ತೀನಿ.
Shall I sit?
Shall I once share my screen and check?
Yeah, please,
please.
please go ahead.
Mr. Arun.
Is that okay, sir?
Yes, very good. Once you make a slideshow. Yeah, very good. Fine. Fantastic.
Mr.
Okay.
Arun.
Good.
Arun. Arun. Mr. Arun.
I have put it everywhere in Foxy groups and Pied Piper group, and then so many groups are there.
Sir, call ಮಾಡ್ಬೇಕಾ ಅರುಣ್ಗೆ?
Because I thought this would be a very useful for everybody all over India.
Yes, sir. Now with so many scans happening, I think we have to know how to handle.
Yeah.
Who is the Abbott representative joining? Madam.
ಈ ತಿಂಗಳಿದು ಇಂಟರ್ನ್ಯಾಷನಲ್ ಸ್ಪೀಕರ್ ಯಾರು ಗೊತ್ತಾ?
ಅದು ಇನ್ನೂ ಡೇಟ್ ಫಿಕ್ಸ್ ಇದು ಮಾಡಿಲ್ಲ ಅವರು.
Yeah, no, actually
transfer we have finalized. Skill transfer program will have cesarean section this time.
Okay, good.
Then you Ksoga young will select.
No, I was thinking can I arrange one international?
See, since the Davanagere conference, we have decided to have the Kcog program only on Thursdays.
Yeah.
First, second, third, fourth.
Yeah.
First is Cpap. Now
Second is
will
international.
be skill transfer, and third will be international.
Yeah.
Fourth
Okay.
will be Yuva. That's how. And
No
other days are left open for anybody who is wants to conduct any program.
Good.
We have made this, it is open.
Yeah. No. Can I arrange one international speaker if Hema is finding it difficult this year? This month?
I'll just talk to her tomorrow.
Yeah.
Then I will come back to you.
Yeah.
ಭಾರತಿ ಅವರು ಇನ್ನೂ ಜಾಯ್ನ್ ಆಗಿಲ್ಲ ಅನ್ಸುತ್ತಲ್ಲ?
ಇಲ್ಲ, she is not joining, Manjula. She's having some emergency. Yeah.
Take over, I think, Manjula.
Okay. Good evening, Sajjan sir. Full background change. Oh, in the car. ನಾನು ಏನ್ ಬ್ಯಾಕ್ಗ್ರೌಂಡ್ ಚೇಂಜ್ ಆಗ್ಬಿಟ್ಟಿದೆ ಅಂತ ಇದೀನಿ.
ನೀನೊಂದು ಚಾವಿ ತಗೊಂಡು ಸುದೀಪ್ ಅಕಸ್ಮಾತ್ ಮಾಡಿ
Manjula.
Sir.
The Abbott executive has not yet joined. They may join later.
Okay, sir.
You can start after the prayer, straight away requesting Dr. Sajjan to welcome. And Abbott will have later.
Sorry, sir.
He is in some meeting that he may join later.
Sorry. So immediately after the prayer song, we can start.
Immediately after the prayer, you can ask.
I'll ask
Dr. Basura. Yeah.
ಅಲ್ಲಿ ಹೇಗಿದೆ ಸರ್ ಕೇಸಸ್? ಕೇಸಸ್ ಹೇಗಿದೆ ಅಲ್ಲಿ?
We have around today 6 cases, yesterday 4. Some
Hubli-nalla?
Not heavy.
Dharwad district.
Sikkim ಅಲ್ಲಿ ಹೇಗೆ?
Sikkim ಅಲ್ಲಿ actually ಅಷ್ಟೇನಿಲ್ಲ. Usually Sikkim ಅಲ್ಲಿ by going by previous 2 years trend, the waves happen after 6 to 8 weeks after rest of India.
Oh. So you're preparing for that?
I don't know. I don't know whether we should prepare at all, because this has become like a common cold now. I mean, we should take it as.
But Omicron death is recorded today. First death of Omicron at Udaipur.
Is it?
Omicron. Maybe other complications with other.
Actually,
Omicron today death
is equally affecting like the previous COVID deaths.
He was 70.
Omicron alone is not going to cause much of morbidity or mortality. Anta, that's what abroad the studies. That's what it's been circulating.
How is that?
So, good evening, everybody. Huh? Good evening, sir. Good evening.
Good evening, Durgada, sir.
Yes, sir. Yes, sir.
How is Manjula is seen in full screen and nobody else is seen in full screen?
Well, whoever is talking, they will be seen full screen. Now Sajjan is full screen.
I'm not coming in full screen. I'm talking,
You are in full screen only.
I'm also in some full screen, huh?
Mm.
Okay. For another few minutes. After that, there will be only one on full screen.
Yeah.
So another 2 minutes.
The national conference postpone ಆಯ್ತು.
Last flight last two. They are not lifting the telephone at all. Flight people.
Oh.
32,000.
We'll get anything back.
You have lost only 32,000.
Only 32,000.
Oh. Yeah, 32.
Luckily, we have not taken.
Flight ticket is that much,
We never returned it,
for 2 people.
Late ಆಗಿ ಮಾಡಿದ್ರ ಅವಾಗೆಲ್ಲ ಎಷ್ಟು 5,000 6,000 ಹೀಗಿತ್ತು.
You have to change 2 flights, Hubli to Mumbai, Mumbai to Indore. There is no direct flight.
Sir, Belgaum to Indore direct flight ಇದೆ.
ಅದು only once in 2 days in a week, not daily.
ಹೌದಾ? Okay. I know the direct flight ಇತ್ತು.
ಅದೇ connection Belgaum to Indore business.
ಹೌದು, business sir, business.
No, Belgaum has got many flights now. Belgaum has got double the flights than Hubli.
No, really, you should appreciate Belgaum airport. Indore flight ಇದೆ. I could not believe.
See, Belgaum is covering part of Maharashtra. Quite a part of Maharashtra, like Sangli, Kolhapur. They are all using the Belgaum airport.
Southern belt of Maharashtra. Very closely connected, alva? Correct. Bharti avralva?
Can we start, Arun?
Yeah, she's in an emergency, Durga.
Yes.
Mr. Arun.
Arun, start the program. Start the prayer. Yeah, it's starting.
कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः शत्रुबुद्धिविनाशाय दीपज्योतिर्नमोऽस्तुते दीपज्योतिर्नमोऽस्तुते शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः.
Actually, इसमें limit होती है ना, so they.
Very good evening to all of you. So after a break, after state conference, we are starting with the first Cpap program from Kcog Ksoga. So without much delay, I request our President, Dr. Basvaraj Sajjan sir, to welcome the gathering.
ಎಲ್ಲರಿಗೂ ನನ್ನ ನಮಸ್ಕಾರಗಳು. Good evening to all. When there was no COVID, the conference was taken successfully, and
Good evening to all of you.
when the COVID has started, we have started our scientific programs. And the first program of Ksoga with Kcog, we are started with a continued professional advancement program. The Dean of the Seema Divakar and the Chief Patron Dr. Hiremet for Ksoga and Kcog and the scientific coordinator, and Muralidhar Pai today is the chairman and a coordinator program, and our Vidya Bhatt is the secretary and our general secretary Bharati Rajshekhar and our Durga Das, and a very eminent speaker of the today is Dr. Chinmay Rath, and very important and interesting and very questionable, very interesting to know everybody. Diagnosis and anomaly. What next? Many will diagnose, but what next is very important. That they are going to discuss. And Abbott has sponsored this program. I invite on behalf of Ksoga and Kcog to all the delegates and faculty and who are all participating. Thank you very much for giving me the opportunity. Thank you very much. I wish grand success for this program. Thank you very much.
Thank you, sir. I request our chief patron, Dr. Hiremet sir, to address the gathering.
Good evening to everybody. At the outset, I would like to thank Dr. Murli for immediately taking up the responsibility of starting the programs for the new year. Just we completed 1 year. Last year in 2021, we started on 4th of Jan, and again this is on 6th of Jan. Last year we have done more than 100 the scientific programs, and all we have witnessed in Davangere. And not only that, the Karnataka College of Obstetricians has honored 21 members in the last conference, and we thought that virtual programs may stop, but fact of the matter is again the virtual programs may be the order of the day for this year also. The way the COVID wave is coming, the way the government restrictions are occurring, and you know that our own indoor conference, which was supposed to be held on 9th, has been postponed indefinitely. I think again the real mode of learning will be again the online program. And as you know that our Kcog programs were very popular last year. They were popular because of the way they were conducted, because we selected the best of the people in the field, and they imparted a great knowledge, and it was a feast to listen to all of them. So many had joined, so many have spoken. I cannot take anybody's name. And again, this year also we are starting with one of the best person in the field of ultrasonography, and Dr. Chinmay Rath. And today she is going to speak on a very practical subject. I think this is the need of the hour, because every time we get a report on our table, anomaly diagnosed. After the diagnosis, what to do is the real question. And today she is going to deliberate on that. And we'll continue to have this program in Kcog on every first Thursday of the month, the Cpap, second Thursday skill program, third Thursday international program, and fourth Thursday will be the Yuva Ksoga, wherein we are going to give an opportunity to youngsters who are less than 40 to be the speakers. Apart from these 4 programs, this year we have made open for all the Ksoga office bearers and Ksoga committee chairpersons to conduct the program at their convenient day. Last year, what we had done is we had fixed 2 days in a week, like Tuesday and Friday. Many of them were finding difficulty to stick on to this. So that's why you stick on now. Kcog will have only on Thursday. Any of them who wants to do a program, who is enthusiastic and be a leader, they can approach the office, fix up the program, and they can conduct the program any day other than the Thursday. I think this will become more flexible, and many more will come forward to conduct. And whoever is conducting the program, they will be called as organizing chairpersons of that program. And for every program, we are taking every time one of the guest honor. And I think we are going to honor quite a good number of people at international and national level who have made a big mark in the field, in the academics. With these few words, I once again invite on behalf of Ksoga and Kcog, our today's speaker, Dr. Chinmayi Rath, and all our Kcog and Ksoga office bearers, and all the delegates who have logged in to know this very, very interesting. At the end of the talk, there will be chat box. Please put up your questions. Dr. Murli will pick up the questions. After that, chairperson's remark. That's how the program will end. And Abhat has taken this responsibility this time. In fact, this executive of the Abhat was to join in the beginning only because of their parallel meeting. He is not able to join. Probably he may join at the end. Thank you very much for giving me this opportunity.
Thank you so much, sir. Now I request our convener, Dr. Murlidhar Vipai, Chairman Kcog, Dean, SN Sikkim, to introduce today's guest speaker, Dr. Chinmayi Rath.
Thank you, Dr. Manjula. As our chief patron, Dr. M.G. Hiremat said, last year, this time, when I was asked to take over as the chairman of a medical education committee, I suggested instead of medical education, let's start academic wing of Kcog as Karnataka College of Obstetrics and Gynecology, and he nicely supported that. It was supported by the executive committee, and I think Karnataka is the first state to have a college of obstetrics and gynecologists. We have conducted every month several programs, as sir was telling that. The first Friday, it used to be first Tuesday in the last year. First Tuesday, we used to have the Cpap, and second Tuesday, we used to have international program. Third Tuesday, we used to have skill transfer, and then the UA. And in the month of February, March, and April, we had conducted a program called We Care that was exclusively targeting the exam-going PGs. We are going to soon roll it out this year also for the benefit of exam-going PGs. The exams are going to be in April, May, all over the country. So probably by the first week of February, like last year, we are going to roll out that program also. That will be only the weekend, Friday, Saturday, Sunday. And the theme of that will be Friday, there will be one lecture or two. And Saturday, there will be case discussion based on that. And Sunday, there will be a Viva item. The theme of Cpap is that we would have a single speaker so that, it can be nicely deliberated, and we will pick up only the management issues for the benefit of the practicing obstetrician and gynecologist. And in the end, there will be discussion. So this way, there will be a good learning, good exchange of thoughts. And we have, as sir was telling, we have chosen different areas which are very practical, which are day-to-day things. And today's theme I have specially picked up because now fetal medicine is a very, very emerging and very important area. It's been there for years now in the West, but it has now really taken the front seat even in India. Here is a specialist who is very dedicated, very committed, very erudite in her field. So her commitment is beyond question. And I thought she's the best person to talk about this difficult subject. Why I'm saying difficult? Because diagnosing anomaly itself is a difficult thing, but then given a high resolution ultrasound or given a good eye for details, one can pick up the anomaly. But what next is not easy. You need to have a thorough knowledge. You need to have analytical knowledge. You need to know how to counsel the patients, because in India, still couple do not accept the anomalies. In the West, we have seen people accepting even Down syndrome. In Malaysia, when I was there, they would never go for abortion if it is Down syndrome is diagnosed. And in the West, we see anomalous kids are welcome. They have got a lot of facilities and things like that. But in India, even if there is a small talipus equinus varus, they want abortion. Does it require abortion? So is it an anomaly or is it a deformity? So these are the things that has to be clarified. And I thought Dr. Chinmayi is the best person for that. As you can see, she's an MRCOG from UK, and she's a FIMSA member as well as fellow of ICOG. The present appointment is she's Director and Lead Consultant Fetal Medicine, Resolution of Fetal Medicine Center, Hyderabad. She is actually also a member of Fetal Medicine Foundation, UK, approved trainer in India, RCOG moderator for ERP MRCOG 2 exam, ICOG Foxy certification course center head for fetal medicine, Ian Donald ultrasound courses center director, peer reviewer of Jogi Journal of Fetal Medicine. So what more do you want? Post presently held chairperson of Foxy Perinatology Committee 2021-23, member representative AICC RCOG 2021-23, treasurer OGSH 2019-21, chairperson Fetal Medicine Committee OGHS 2019-22. She has won several awards, as you can see here. Asia GCC Award for Excellence in Leadership in Healthcare, APJ Abdul Kalam Award for Medical Excellence, Rajat Ray Fetal Medicine Award, Wonder Foxian Award, Foxy Young Author Award, and Best Paper Prize at APCOG, CS Don Gold Medal for Best Research Paper. So 18 research papers have been published in peer-reviewed journals, co-authored one book on MRCOG Part 2 exams. I'm very, very happy to introduce the most erudite person and most apt person to deliberate on this particular difficult aspect or difficult subject, Dr. Chinmayi Rata. I always wanted to have her as a speaker in a Karnataka conference. I promised this long back, and today it could happen. Over to you, Dr. Chinmayi.
Thank you so much, sir. It's really very humbling because some of the stalwarts of our field, like yourself, Hiremat sir, Sajjan sir, it's really a humbling experience to speak in front of you. And indeed, I've just been listening to all that is being done to improve the quality of education in Karnataka in OBGYN, and I think that's a really nice initiative to start this College of Obs and Gynae, as I don't think any other state has it. So it's really an honor for me to be present here amidst all of you to discuss a topic which is again something very, very close to my heart, that once we diagnose an anomaly, what do we do next? So we all know that the incidence of structural abnormalities in a fetus is about 3 to 4% of all live births. So even in a routine obstetric clinic, in a week, we might encounter 2 to 3 fetal anomalies. That is in a routine obstetrics OPD, where it's not particularly called a high-risk OPD. Even then, you could encounter these many abnormal reports in a week. And malformations, they may be either a abnormality in development, where an organ is either not formed or partially formed or formed in an abnormal manner. The thing is, once we diagnose the anomaly, that's only the beginning, because the report might end with the diagnosis of an anomaly, but for the obstetrician, that's the beginning of a very long journey, because you have to start counseling your patient sensitively as to what is wrong with the fetus. Nobody expects an abnormality when they go for an anomaly scan, and how to deal with it based on contemporary literature and available technology. Some anomalies are really unfortunate because they are just not compatible with a normal life. They are uniformly lethal postnatally. And in these cases, like anencephaly, anencephaly, limb body wall complex, or major multisystem anomalies, it's actually reasonable to offer termination of pregnancy. But then if the anomaly is correctable, and there is a method that, if you handle this correctly, it might be compatible with a reasonably good quality of life, then it demands a complete workup, a genetic counseling, and a plan for further care. Because remember, the answer to a crisis in pregnancy is not always to eliminate the pregnancy. It is just to eliminate the crisis. So every anomaly does not need termination. And the diagnosis of an anomaly is only the beginning of a long journey towards caring for the fetus in a manner that you achieve the goal of a reasonable perinatal outcome. So, like I said, even if it is a very common anomaly like clubfoot, the diagnosis of the anomaly comes as a shock. So when a woman who's a 26-year-old gravida goes for an anomaly scan, and the doctor tells them that everything else is okay, but there is just clubfoot, even then the parents take it as a major problem. They think that something is grossly wrong with our baby. So what happens then? They just come to the obstetrician and ask, doctor, what is wrong? We went for the scan, but the doctor said there is something wrong. Now, how best to counsel the family is what is the obstetrician's dilemma. Now, this science of fetal medicine and the science of obstetrics actually is all overlapping each other, because fetal medicine specialists are not people who have some different, set of organs in their body. But the only thing that they have is a training which tunes them to handle these issues in a more objective manner and try and understand that anomaly in a way that it can be put into perspective. So here, when you have to counsel the patient with a unilateral clubfoot, what do you need to know? You know that clubfoot is a correctable anomaly, but then is that clubfoot an isolated anomaly, or is it part of some system or systemic syndrome or something else? So what you need to understand is, what is the screening history? Has the first trimester screening been done? Is this baby low risk for other aneuploidies? Because if not, then it could be a part of some kind of a aneuploidy syndrome that has to be ruled out. How is the spine of the baby? How are the movements of the other joints? And is there any family history of similar issues? Because if you see, each of these questions systematically rules out some possibilities. So if the screening history says the screen is low risk for aneuploidies, you know that it is unlikely to be associated with any of those. If the spine and the movements and other joints are also affected, then it may not be just a clubfoot. It may be a part of an arthrogryposis multiplex congenita syndrome. It might be a part of a neurological abnormality, and then the prognosis changes. If there is a family history, there are sometimes families where, there has been clubfoot in every generation. Then you know that it is a genetic syndrome, but since the other people have had clubfoot and had reasonably good lives, you would understand that that is part of that kind of a syndrome. So always analyze, understand, and explain the problem to the patients so that they get a clear picture of what that is. Now here, it's only clubfoot, but before you write it off as only clubfoot, you need to do this entire exercise which we discussed. And after that, maybe get them to meet the neonatologist, because for us, we read about these anomalies, we know their natural history, we know it is treatable. For us, it's common. Coming to the hospital is a way of life for us, but for the patients, they don't expect to come back to the hospital once the child is delivered. So we need to explain to them that, look, very early in life, it will not cause a problem. There are methods of manipulation which is going to take some effect on the baby's feet as the baby grows, and thereafter there are other methods of treatment, and one day your baby can have a very good posture and a very good way of walking and running, and that will not be a big problem. So it is good to let them meet the neonatologist, and if necessary, the pediatric neurologist. Not in every case, but in any case where you think that there might be a reason for them to be worried, and then reassure them that this problem is completely manageable. Visual aids help. So we use these kind of pictures where we show them that, these are the kind of plasters that are put into the baby's feet after the baby is born. And this gives a correction because the bones are tender, the ligaments are tender, and then they can take the correct shape and things can get better. So isolated clubfoot is completely correctable. It has a good prognosis, and you don't need any specific intervention antenatally. Postnatally, all this can be done. And before the baby actually has to walk, a lot of this musculoskeletal correction can be achieved. This kind of counseling helps the parents get some confidence that this is a problem which they can easily manage, and therefore they don't get completely devastated with the diagnosis of the anomaly. In fact, it helps them be prepared about the anomaly from the beginning. This is another case where, there is a second gravida with a previous cesarean section for CPD who has come for a 19 weeks anomaly scan. And what can you see there? You can see that the contents of the abdomen are protruding outside. So instead of having a smooth abdominal wall there, we have contents of the abdomen like the bowels protruding outside from the anterior abdominal wall. And this is nothing but an anterior abdominal wall hernia, which is most likely an exomphalos here because there is a membrane covering it. Now, again, the same story starts. Is this baby screened? Is it low risk for aneuploidies? Because all abnormalities can be associated with chromosomal abnormalities. So if a screening history is not available, it puts you at risk of all these problems right away. But if a screening history is available, that's very reassuring because you've ruled out a possibility of many aneuploidies. Then the second question is, are there any other abnormalities? Is it an isolated anterior wall hernia, or are there other abnormalities? So if there are other abnormalities, the prognosis becomes worse because, it becomes a multi-system problem. Then comes the question to the obstetrician, do you need to modify the antenatal care in any way? So these kind of problems generally lead to polyhydramnios, and the obstetrician has to be aware of the fact that there could be polyhydramnios, which may not only increase the chance of preterm birth, but also may necessitate an operative delivery, because there will be malpresentations or these kind of complications. Should you be delivering them at any place and transferring the baby for care, or is it a good idea to deliver them at a place where exactly the postnatal surgical correction will be available? Does this entail the need for a preterm birth, or it should be a normal natural birth at the time of full term? So these are the dilemmas that the obstetrician has to handle. And then comes the role of the pediatric surgeon, because this kind of a problem will be handled by the pediatric surgeon postnatally. So you also need to talk to the pediatric surgeon and get his opinion, who will actually tell you that this does not need preterm delivery. It has to be a term delivery. During the delivery, one should avoid inadvertent rupture of the sac so that the risk of infection is minimized. A neonatal care has to be given to stabilize the baby before surgery, and then you have surgery and postnatal follow-up. So the neonatologist becomes an important link between the obstetric care and the pediatric surgical care, because the transition of that baby from in utero life to ex utero life is taken care of by the neonatologist. So if all these people talk to the parents beforehand, as soon as the problem is diagnosed, you do a genetic workup, you talk to the neonatologist, you talk to the pediatric surgeon, then there's a complete chain of care that is formed. It gives a lot of confidence to the parents, and then final outcome becomes good. So this particular baby had an elective cesarean section at 38 weeks. A 2.3 kg female baby was born, and after a few days of birth, surgery was done, and the outcome was very satisfactory. So why is this antenatal counseling important in anomalies? Because it gives you a primary awareness of the exact condition, its general prognosis, and what inputs do postnatal surgery involve. Sometimes you may have to transfer them to a different center for the surgery. There is a cost and time involvement. The local data of outcomes, if there is a particular center which is much more specialized and which does all these tasks for a long time, then it is a good idea to get their local data and tell the parents that this is a center which is far more specialized in this, so you can have the surgery in this place. There may be a need to travel to these places for better results and the continuity of care. So all this information is empowerment for the parents. So if they are aware of these cases, these conditions before the birth of the baby, then they can be empowered to take care of the problem thereafter. Now, remember the importance of genetic workup. In the previous case, I told you that we had to look at the screening history. Now, this was a case of exomphalos, which is, again, we know everything about exomphalos. We know how we can diagnose it. But this was a case of exomphalos where the patients wanted to continue the pregnancy. But when you did a CVS, we found that there was a major aneuploidy like trisomy 13. So in this case, the entire story changes once the diagnosis of an aneuploidy is made, because the anomaly here is not an isolated anomaly, but a part of an aneuploidy sequence. So here, even if we manage to get surgery done, even if we manage to get everything done, the final outcome would not have been good. So in this particular case, despite the parents willing to continue the pregnancy, we had to ask them to discontinue, and the outcome of that particular case was different. So then comes anomalies in the face. Now, we all know that we can visualize the face very well in the ultrasound of the present day standards. So just by two views, the profile view and the coronal view of the face and lips, we are very, very confident of diagnosing problems like cleft lip and palate. So diagnosing these problems is not very difficult, and they are very common also. But then the problem is, as soon as you tell them that there is a problem in the face of the baby, there is a great deal of anxiety that is created. And although this has very good correction, somehow the parents are completely thrown off guard, because the face of the baby is the first thing that they see when the child is born. And it is very, very distressing for them to think that the face will be distorted. Also, there are a lot of issues with newborn feeding when there is cleft lip and palate. So till a few years back, it's something that even I felt that although it's a very correctable abnormality, our patients were not very, very keen in continuing, and many of them used to get disheartened and discontinue the pregnancy. Now, what has happened now is we know that these conditions get better, but one thing which really changed our outlook to these anomalies and made it very, very acceptable for our patients was this project of the government of Telangana called the Smile Train, which is run in the plastic surgery department of the Nizam Institute of Medical Sciences. It's a government aided program where they provide free surgery for cleft lip and palate. And the doctor who heads this project, Dr. Parvati, she is so passionate about the program that she is very happy to share her number with the parents. So although I work in a private sector, I am able to tell them that, this help is available, and they can go and contact Dr. Parvati and her team antenatally, and they get a very good response from there. They get information leaflets about the problem, and they get a very clear plan of how postnatally they can be managed till the time surgery is done. So they are given a lot of visual inputs. They are given these kind of, these are babies who've had correction for the surgery, and showing this kind of the showing the outcomes like this and giving them a clear plan of how treatment will happen. It has led to a lot of patients accepting this problem much more, and now our continuation rates with cleft lip and palate are actually very good. So just the intervention of providing more information, providing a clear plan postnatally, and giving this kind of local data outcomes that, our patients who have had surgery with us have had good speech and good hearing outcomes after cleft lip palate surgery has encouraged many patients to continue the pregnancy despite the anomaly. Then there are other problems like, hydronephrosis. Here, what is important is we have two kidneys. So we all know that with one kidney also the quality of life is reasonably good. So even if a very severe kind of anomaly is affected on one side, the other kidney being normal usually leads to a good quality of life. For example, here you see there is severe unilateral hydronephrosis. So although it's really looking bad on one side, the other side has a normal kidney, and that should be enough for the parents to believe that they can continue this pregnancy. Even if you have to take off this kidney later on, or there are issues with this kidney, the baby will have a good quality of life, and that need not be a reason for termination of pregnancy. So whenever you have these prenatally diagnosed surgical conditions, it's important for us to have a multidisciplinary team with the obstetrician as the center point, the fetal medicine specialist as a very close shoulder, and the neonatologist and pediatric surgeon as the other wheels on the spoke, so that we really get a very concerted effort to get every anomaly reach a logical ending. Then comes the fetal chest. The fetal chest is a very specialized area where you have two very vital organs, the lungs and the heart. Two lungs are flanking the heart, which occupies the mediastinum, and any space occupying lesion here can have a problem, can cause a problem in the entire systemic development of the heart. So if you see the fetal chest here, the normal fetal chest has been shown in these two pictures, whereas abnormal lung masses can occupy any area of the chest, and they can cause severe mediastinal shift, leading to a problem with the functioning of the heart and the development of the lungs. So when that happens, the overall outcome will be bad. So this needs some kind of treatment. Now, when you look at lung masses, there are masses which are directly in the lung. There are masses which arise from the pericardium, which arise from other areas and present themselves in the lung. So there can be a lot of differential diagnosis as shown here. Now, what finally makes the prognosis is where exactly is this mass coming from and how is it affecting structures in the mediastinum. So one of the commonest chest lesions that we see is the congenital diaphragmatic hernia. So there is a hole in the diaphragm, and because of that, all the abdominal contents move into the thorax. So there is a hole, and thorax and abdomen are exposed to each other, but the thoracic contents are very fixed. The lungs are fixed by the trachea, and the heart is fixed by the blood vessels. So it is the mobile intestinal, the abdominal contents like intestines and liver, which move into the thorax. Now, what happens is when that moves into the thorax, it see, when the intestinal, the abdominal contents move into the thorax, they displace the lungs. On the same side, the lung is completely compressed. On the other side, it is compressed by the mediastinal shift. So the outcome finally depends on how much of the normal lung is remaining from the opposite side, because on the same side, we assume the lung is completely compressed. So in these cases, the prediction of the prognosis is done by a method called the lung head ratio calculation. So whenever we see a diaphragmatic hernia on the left side, we measure the right lung area that is left and compare the right lung area to the head circumference and get what is called a lung head ratio. Now, lung head ratio observed upon lung head ratio expected. What would have been when there was no compression? What is it when there is compression? So this is expressed as a percentage. If that percentage is less than 25%, then we suspect severe lung hypoplasia on the right side. And the severe lung hypoplasia cases will not do well. So even if you do a postnatal surgery, you will not get a good outcome because the lung is hypoplastic. You might take back the intestinal contents, but the thorax will not fill up with that lung. So you need to have a good prognostication for which cases will do well with surgery. Only if this ratio is more than 25%, you can expect that after surgery that baby will do well. And that is very important. So if the baby does well, then there is a very, very specialized kind of newborn care that is required in cases of diaphragmatic hernia. Sometimes we do what is called an exit procedure, ex utero intrapartum treatment, where the baby is delivered, but even before it makes an attempt for respiration, it is ventilated so that there is no swallowing of air. When it swallows air, the intestines and the stomach will inflate further and they will cause more compression on the chest. So instead of that, you ventilate the baby and ventilate directly into the airways. Do not cause any inflation of the orogastric tube. Similarly, bag and mask ventilation has to be avoided in these cases, and they are maintained on that ventilatory parameters. Once they are stabilized, a surgery is done, and then the lung is expected to re-expand, and once it expands, then the outcome is likely to be good. If it does not expand, then it is likely to be bad, because if it does not expand, there will be very high pulmonary hypertension, and even with postnatal surgery, the outcome will not be great. So in congenital diaphragmatic hernia, we do this. This was one case where 24 weeks it was diagnosed and the lung head ratio was found to be 34%. 34% said reasonably good outcome with surgery. And when they continue the pregnancy and do this entire procedure of an exit procedure and NICU support, the babies can do well. So this is a correctable anomaly provided we prognosticate it correctly and do the right things in the postnatal period. Now here, let me tell you, this particular treatment is not yet available in India, but there was one anomaly which led to the prophecy that this anomaly could be handled better, and that is that I just told you that when the intestines go into the thorax, they compress the lungs and then they spoil the prognosis because the lungs get completely deflated and their area is not, their volume is not maintained. So one of the solutions that came here was from that abnormality called Kcog. Kcog is a abnormality where there's a high airway obstruction. Congenital high airway obstruction sequence is called Kcog. Now in that condition, what happens is the lungs are very voluminous because the lung fluid cannot escape because of the high airway obstruction. That leads to high drops. That is a lethal anomaly. But given that anomaly, there was this idea by which some of the people used and said that if we can obstruct the trachea of a baby who is affected by congenital diaphragmatic hernia, then the lung fluid would remain inside and would not get a chance to escape even if there was pressure by the abdominal contents. So this treatment for diaphragmatic hernia, a palliative treatment in utero, started by what is known as fetal endotracheal occlusion, FETO. So using a fetoscope, one can reach the trachea of the fetus and put a balloon there and inflate it to obstruct the lumen. When that happens, then the lung volume is maintained. So even if there is more pressure from the external abdominal contents, the lung volume is maintained. And in cases where there would have otherwise been severe hypoplasia, once a feto is done, the lung volume is supposed to be maintained. And there are some local, factors which help in the acceleration of lung growth. And therefore, the final outcome with the surgery would be good. This would still entail the need for surgery after birth, but the outcomes of surgery would be better because the lung volume would be better. We still don't have this treatment in India as yet, but I'm sure at some point we will start this process also. And there is a huge trial that has been conducted in Europe called the TOTAL trial, tracheal occlusion to accelerate lung growth. And that has proven that, yes, it helps in cases where there is a risk of severe, moderate to severe lung hypoplasia. There are other lung abnormalities like the Cpap. Now you see, CDH was when the lung was replaced by abdominal contents, but in Cpap the lung is there but it is abnormally growing. And if you see this picture, it looks so abnormal. There's a huge mass there in the chest and the heart has been pushed to one side. It really looks very scary and you think this is really bad. But the good news is the natural history of Cpap is 90% of them resolve. It is just a delayed maturation kind of picture, and 90% of them resolve in the antenatal period. So if you just keep a follow-up, many of them will resolve. Some of them are macrocystic, the way you see here. There are big cysts. And if there is a dominant cyst, then we have to calculate something like a Cpap volume ratio. And if the volume is very high, then you know that the risk of hydrops exists. So in microcystic Cpap, there is a role of giving betnesol antenatally to reduce the lung expansion, the volume expansion of a Cpap. It's still experimental, but can be done. And in macrocystic Cpaps with a dominant cyst, there is a role of aspirating the dominant cyst, or putting a shunt into the dominant cyst so that it gets drained out and the Cpap volume becomes manageable. So if the Cpap volume ratio is more than 1.6, it is a predictive factor for the risk of hydrops. And in those cases, an aspiration can be done. So we had one case like that where we had a massive lung cyst, which was aspirated, and then the baby did well thereafter. So these are some cases where we have a role of doing fetal intervention, although that is not a curative treatment, because the same baby who went on to term and delivered healthily continued having persistent cough. And at 16 months of age, she had to have a chest surgery and the removal of that lobe which had the Cpap, but she's doing very well post-natally. So the fetal intervention helped to continue the pregnancy till full term, and thereafter the postnatal surveillance helped to detect the time when surgery could be done, and finally she is leading a good and happy life. This was a case which was referred to us at 31 weeks with an abnormal head shape. So you see the head shape is completely abnormal. It looks like what is called the clover leaf head. And this was because of premature fusion of some sutures, which causes, it's a kind of craniosynostosis, and which causes this abnormal head shape. So initially it was very scary, but when we spoke to the neurologist, he said, no, there is no need to worry. And the internal brain development is not affected. It is only the shape of the skull that is affected. And right now it won't cause any problem. Postnatally, we can do surgery and correct this condition. So if we had not met the neurosurgeon, we would have not known what that condition is and how it is managed. But he said, don't worry, let the baby go to full term, let the baby deliver, and then I'll take care of it. So this baby went on to full term and delivered. And as you can see, there was some dysmorphism at the time of birth. And if it had not been managed, then further the brain development and everything would have been affected. But after the birth, they went ahead and followed up with the neurosurgeon, who did all the workup. And if you can see here in the CT pictures that the midline suture is already fused abnormally, and what they did was a fronto-orbital reconstruction and a biparietal release. And after that, you see the baby has now, after the surgery, she had a very nice head shape and her brain development was all going on normally. So this was again one problem which was diagnosed antenatally, but with a proper counseling, she managed to have a good postnatal outcome. This is a case of rudimentary limb. You see there is an extra limb attached to the back of the baby. This was diagnosed pretty early in pregnancy, but the patients decided to continue the pregnancy, and we had kept a differential diagnosis of a parasitic twin, but it looked more like an extra limb attached to the back of the baby. And this was the child which was born. The thing is, it was already diagnosed and the parents knew about it. So, we can't change many things by antenatal diagnosis, but education is empowerment. So once they know that this is there. They are really well prepared to handle this situation. And this was quite a, significant mass there in the back of the baby, but they were aware that this is there and this has to be corrected. So after about a week or 10 days of birth, she had a corrective surgery, and that whole mass was excised because it was just an extra limb attached to one portion of the baby's body. And then there was just a minor scar there, and the baby is doing well. So this was again another correctable anomaly, diagnosed in time, counseled well, worked up, and then went on to have a good outcome. Then this was a particular case where we saw abnormal drainage of the pulmonary veins. The normal pulmonary veins drain into the left atrium, and that is how the left side receives the oxygenated blood from the heart, from the lungs. But what happened in this case was there was an abnormal drainage of the pulmonary veins, and because of that, this was what is called as the total anomalous pulmonary venous connection. Now again, this is a condition antenatally does not lead to any problem, because antenatally all the oxygen is coming from the mother. The heart lung issues will only surface after birth and after the closure of the ductus arteriosus, because till that time there is always some shunting happening, and oxygenated deoxygenated blood keep on mixing with each other. But after the closure of the duct, then these problems become apparent. So in a normal situation, if you have not anticipated this problem and you have not diagnosed it immediately after birth, because it may not present as something drastic immediately after birth, after 3-4 days, the baby starts deteriorating, and then it suddenly comes to the hospital with something. And if the emergency doctor is unable to diagnose it, then it just goes on as a cot death or an aspiration or something. We never get the right diagnosis also. So it's very important for us to be aware of these conditions, because TAPVC can present as, just minor suboptimal oxygenation of the baby in the first 2 days, 80-85 saturations, things like that. But if you have diagnosed it, or if you've got it at that time, then it is a completely correctable anomaly. It's just a connection problem, and the connections can be reset, and the outcome will be good in those cases. So this was one case where it was diagnosed, the pediatric cardiologist was involved, and finally the baby had postnatal surgery, and it did well. So for every anomaly, there is a very structured method of working up what are the details of that anomaly which affect the prognosis. So involvement of a fetal medicine specialist, involvement of a pediatric cardiologist, involvement of the neonatologist in all the anomalies. I don't want to go into the specifics of each anomaly, but as a general rule, the role of involving a multidisciplinary team is getting the best of each person's experience, each person's expertise in that particular condition. So when we talk of an anomaly, we need a full army to manage that abnormality. And that is one of the most important steps in making a care plan for any fetal anomaly, because what the surgical repair entails, how much will it put a tax on their cost issues, on whether they have to travel to another place, how long will the baby have to be in surgery, how long will the baby require to recover completely, what are the limitations of life long term. Once we know all that, it's very easy to make a rational decision of whether these things are acceptable or not acceptable to the parents. If they are not acceptable, they may choose to terminate the pregnancy. That's fine, because it's a personal choice, and I don't think we should be judgmental about that. But if they choose to continue, we should have a clear plan of what we can offer them, how much it is going to cost them, what is going to be the reasonable outcome in these cases. And should the case fail, should the surgery not go well, should there be complications, they should be mentally prepared for that, because for us it's just one out of many cases. For them, that's the center point of their life. So please involve the parents in this kind of counseling, and then they can do well. So with heart defects, we always classify the heart defects into 2-3 types. So one where there is too much blood that passes through the lungs, one where there is too little blood that passes through the lungs, and one where there's too little blood that passes through the body. So if you make these general classifications, as obstetricians also, you will be able to understand. You don't have to remember each and every defect in detail. It's not possible. It's not possible. They are intimidating. What happens usually is it's very scary when we talk of strong terms, in terms of anomalies, in terms of some kind of heart defect. It becomes very scary. What are they talking about? But if you know that these are the major problems and this is exactly how they have to be handled, then I think it will become more easy and acceptable to talk about it and to explain it to your patients. So all kinds of heart defects do not cause problems. Simple things like ventricular septal defect, atrial septal defect, double outlet right ventricle, TGA, transposition of great arteries, these are all conditions which can have very good postnatal surgical results. So only thing that we need is to rule out other coexisting problems. And with heart defects, always good to rule out chromosomal abnormalities or any other genetic syndromes that we can think of. And now the tests are available, so one should do that. When planning delivery, one has to plan it at a center where there is appropriate level of care for the mother and the neonate. Neonates with duct-dependent lesions and with critical cardiac lesions should be delivered in a facility with level 3 NICU with a pediatric cardiology backup. So American Heart Institution has given us a list of diseases which can be delivered even under normal NICU circumstances, and others for which you need specialized in ICU care. So there is a list available here. It's a free downloadable document by the AHA. So once you see that, and the advantage of involving a pediatric cardiologist is he'll tell you directly, and that will give you medical legal backup also, that, I didn't need to deliver this baby in a tertiary level care, because sometimes it's not possible. We get patients from 250 kilometers away, 300 kilometers away. All the time, they are not willing to come and deliver at a big city just for the sake of delivery. They are happy to bring the baby after birth. So whatever circumstance suits you. So if it's not a disease which requires care immediately, like say a ventricular septal defect, the baby does not have to deliver in a high-tech center right away. It can deliver in its own place and then come for postnatal checkup with the pediatric cardiologist. So this awareness of which disease needs to be delivered where is important for the obstetricians. So similar guidelines can be developed in pediatric surgery units. So it's important to keep talking to your parallel specialties. So for the pediatric surgeons also, is this problem correctable? Is the surgery available at our center or nearby physical center? Is the outcome of surgery reasonably good for us to opt for it? What are the financial time and resource requirements? And what is the expected outcome long term? These are standard questions. This is an article which I had the honor of writing for the STUD Current Progress in Obs and Gynae series, where we have highlighted on optimizing multidisciplinary perinatal care in correctable fetal anomalies. And there everything comes down to a effective multidisciplinary team with a good communication line with each other, so that the problem is not only identified and analyzed, but also taken to a logical conclusion. So the common prognostic factors for any fetal anomaly will be whether the anomaly is an isolated anomaly or a part of a multi-system abnormality. What type of organ is involved? See, limb abnormalities will have a different prognosis and a different way to look at it. CNS abnormalities will have a different way to look at it. Renal abnormalities will have a different way. So every specific anomaly has a specific, picture around it, and that needs to be understood properly. Any associated chromosomal or genetic problems, any additional risk factors for preterm birth, for example CDH, for example exomphalos, you have a very good treatment plan in place, but then if the baby delivers preterm because of the polyhydramnios, all that falls into the background, because in a preterm baby doing surgery for GI problems is not that easy. So that is why additional risk factors for preterm birth need to be handled. The availability of facility for multidisciplinary care and effective communication and coordination between the multidisciplinary care. For example, you've done everything, you sent to a pediatric surgeon and he's like very blasé about it and he doesn't really talk to the patient in that tone. That will spoil their ability to continue that pregnancy. So your communication in between the team members of the multidisciplinary team is also very important. So at our center, we always try to help couples with diagnosed fetal anomalies to optimize further care in this pregnancy and after birth, to devise a multidisciplinary care team to cover all the aspects of postnatal care. One of the important things we are working on is getting health insurance for sick fetuses. For example, we saw in cleft lip and palate. Once the government aided in the treatment, the the uptake of the anomaly was much better. So the same thing we should have with others. Last year, there was some bill passed about insurance for congenital anomalies, but still that needs to be taken forward. There are some governments which support heart disease corrections, but for all other abnormalities, we should try and drive the mandate towards health insurance for the fetuses, and to think about fetal health care assurance. So antenatal counseling of a fetal anomaly involves prognosticating it, planning antenatal care, planning delivery, neonatal care, and follow-up. And it is better to revisit the issue with the parents and explain the dynamics rather than thinking that, we'll confuse them by talking too much. It's never confusion to talk too much. You should try and keep talking to them to keep their motivation high, although you know that everything has to be dealt with postnatally. So there is no need to talk about it antenatally. It's better to keep talking to them. Now, patients will always ask, can you give us a guarantee, doctor? When we do all this, will you be able to guarantee that everything will go fine? The answer is always no. We cannot guarantee anything, but only thing we can guarantee is we cannot cure everything, but we will definitely care for everything. Now, before we close, this is something I always want to share with people who talk about continuing fetal anomalies, that while I have painted a very rosy picture of many anomalies that, yes, if you continue, there can be an outcome, which is all very good. Sometimes the outcomes are not very good. And this was one case where the primigravida couple, engineers, both of them, had a spontaneous conception, and at 18 weeks, we diagnosed a left-sided CDH. The lung head ratio was 31%, and they were counseled. They wanted to continue the pregnancy. They were very, very keen, and they said nothing doing. The mother particularly was very keen, and she said, nothing is going to change my decision. I am going to continue the pregnancy. So at 38 weeks, we discussed all the options of delivery. And because the fact is, if she comes in labor in the middle of the night, suddenly there may not be everybody available. She chose that let's do a planned cesarean section, and I want the best for my baby. So a planned cesarean section was done, and the senior neonatologists were available. Everything was done by the book. But for some reason, the baby's lungs did not expand postnatally. The baby had a very poor response, and on ventilator, it was always at high settings. So the surgeon said there will be no use doing this surgery, and it's better not to operate, and it's better to let the baby go. So after 48 hours of birth, the baby died. Now, this was a couple who was with us right from the beginning, extremely well-educated couple, and a decision taken mostly by their persistence, but very well supported by us, and the baby died. And then I asked that mother in the postnatal wards that, do you ever regret? Because, when I look back, many of my colleagues told me, why are you persisting? Just let them terminate the pregnancy. She'll have another pregnancy. But she wanted to continue it so bad that I didn't want to give it up. And now she has a cesarean section and she doesn't have a baby. So at some point, even I was feeling guilty. And I asked her, do you regret the decision of continuing the pregnancy? Do you regret what happened? And she wrote me a letter postnatally, and I can never forget these words. She said, I never regret that decision, doctor, because my baby did not end up being a medical waste product of termination, but saw the light of the world. Because of that, I am a mother today, not just a woman. The fetus which was to be terminated, which was told to be terminated by everybody, came into this world as a baby boy and has been named Pradyumna. And I still have goosebumps when I read this letter, but she was very, very vocal when she said, today I have a new identity. I am a proud mother of Pradyumna. And this is how she felt about continuing the pregnancy with a fetal anomaly. Because, termination of pregnancy for us might be just a clinical activity, but for a parent, it might mean something completely different. And she had continued the pregnancy with an anomaly. She had made every attempt for the anomaly to be corrected. We had provided every possible service, but somehow it didn't work out because not all anomalies end up being totally corrected. So complete education, complete awareness, and when it is an informed decision of the parents, then the outcome is always reasonable. I won't say always good, but always reasonable, because even if we fail, we know that we tried our best and we failed despite that. So there are no heartburns anywhere that, I was not told this, I was not given this option. So with that very humble note, I would like to stop here by saying that whenever we diagnose an anomaly, we have to remember that we may not be able to cure everything, but we can care for everything. Thank you very much for a very patient.
Yeah. Dr. Chinmayi, that was really, really wonderful. Pradyumna is the testimony for your erudite, for your care, for your concern, and whatnot. I feel justified in selecting this particular topic and selecting the speaker as well, because this is a real situation for all of us. And especially unless we have the accurate knowledge, unless we know everything, we will not be able to counsel the patients properly. Either the baby will go to a dustbin, or actually that would actually become a hero tomorrow. I have given so many lectures, but one area I don't dare give is fetal medicine. So this area, I don't want to go anywhere near. A person like you only can be very confidently giving these kind of talks. So thank you very much for accepting despite the inconveniences that you had. And I think there are lots of messages of complimentary messages only. Excellent, Chinmayi. A woman became a mother and a fetus son due to your counseling and humane heart. Dr. Bharati Rajshekar. She is our secretary of Kcog. And Dr. Manyata B. Prasad has written excellent talk, Chinmayi. Thank you very much. Shobha Shaivi has written wonderful talk. iPhone to everyone. Thank you, ma'am, for inspiring us. It must be a youngster who is trying to get into fetal medicine. And Dr. Sonia Mandapa, wonderful presentation, Dr. Chinmayi. So full marks to you. I don't see any questions because I think Dr. Durga Asrana, our treasurer, also has now written excellent talk.
It was a flawless talk.
Yes.
Beautiful presentation.
And you were just, the words were coming from your mouth as though just, it is such a easy flow.
It was just like a movie. And the slides were so excellent.
Yeah.
The images were so much communicating. And I really loved the presentation, the slides, coloring code, everything was very excellent and flawless presentation, ma'am. Congratulations to you.
Yeah.
Thank you.
So this is a different kind of talk in a way, because it's not their ready-made. This kind of a chapter is not their ready-made. You have to really talk out of your experience, what you did and what actually happens. And it's only you who could do the justice for this.
Thank you.
Congratulations.
And congratulations on that chapter on stud volume.
Thank you, Chinmaya.
Murali, can I talk?
Thank you very much.
Can I ask
Please,
one question?
one by one.
Can I ask one question?
Please go ahead, sir.
Yeah. Dr. Chinmay, it was an excellent talk. I have two questions. One is, what is the role of genetic testing in case of once you diagnose anomaly? In what all cases you are supposed to go for amniocentesis or and get the genetic analysis? This is one thing.
The thing about genetic analysis is like earlier we knew very little. So with chromosomes, we would be very happy. Now, with the expansion of knowledge in genetics, there are things like microdeletions, microduplications, and a lot of problems which have come up, which are now available for testing. So as a policy, whenever we see any major anomaly, we advise the couple that if you want to rule out what can be ruled out, then let us just go ahead and do an amniocentesis and send it for a cytogenetic microarray. Earlier, we used to do a chromosome analysis in the form of a karyotype. Karyotype is a very basic counting of the number of chromosomes. In a microarray, in addition to the number of chromosomes, we can also see minor microdeletions and duplications, which have pathogenic variation sometimes. So even in conditions simple as absent nasal bone, we are sometimes finding these pathogenic microdeletions. So as a policy, whenever there is an abnormality, we give them this option. If it is a more complex abnormality, then we involve a clinical geneticist and discuss if there is a role of doing like a panel. We have some ventriculomegaly panels, we have some skeletal dysplasia panels. So some of these, there are particular gene testings in certain areas.
Should we do for every anomaly tested? Like even if you are terminating, the patients will ask in the subsequent pregnancy, what is my risk of repeating the same problem? Should we get analysis in every anomaly we have diagnosed?
Ideally, if there is an anomaly, we should offer it to everybody. If they don't do it, like suppose cleft lip palate, if you do it for 100 patients, maybe in 99 you won't find anything. But for that one case where it might be because of some genetic condition, if you have offered it, you are absolved. So this is an area where a little bit of your art and science of medicine will come together, where we offer it to everybody. But we don't push for it if they don't bring, because in our country, cost is a very big problem, sir. Because when they have to terminate a pregnancy, at the same time getting all the genetic workup done is a lot of cost. So one way of bypassing that is getting DNA stored. So suppose there is a couple who you feel want to get the DNA testing done, but at this moment taking up the cost of the termination as well as the cost of testing is very difficult, then we can offer them to store the DNA of the product of conception. The DNA storage costs something like 2,000 rupees. So they can just store it. That will be there for 3 years. So after they have come over the trauma of the termination, then they can do the genetic workup if they want to later on.
What's your say on fetal autopsy? What is the
time up?
What is your say on fetal autopsy?
It is a good practice, sir. Every time, if we can demonstrate whatever we have diagnosed on ultrasound, if we can be demonstrated on our autopsy, then that is definitely added plus point to your diagnosis. Also, a few more problems may become apparent in doing an autopsy. For example, there's a GI abnormality which has not yet surfaced. When you do the autopsy, you might realize that these problems were also there. So classifying the anomaly as a vectoral sequence multisystem anomaly or a specific syndrome-based anomaly is easier if you do a good autopsy. But again, good autopsy has to be done, because that also there are many ways of doing an autopsy.
Thank you.
Dr. Bharati has raised the hand. Do you want to ask any questions,
Thank
Dr.
you.
Bharati?
No more questions.
Dr. Chinmayi, at the outset, no words to express the excellent presentation, and my apologies for joining late for the meeting to our Chief Patron and Dr. Muralidhar Pai and all the Executive Committee members. Just one thing I would like to know is, do you have any specific consent form when the couple have a baby with some abnormalities and we counsel them and they continue the pregnancy? Is there any different type of a consent that we need to take regarding that we have informed them about everything?
No, ma'am, we don't take any specific consent like that. We write everything on the report. Like on the report, we write that, and as a policy, they also accept it. So sometimes they countersign on that report when they take the report, but we don't have a specific consent form like that.
Okay, thank you, Dr. Chinmaya, and excellent and congratulations.
Thank you, Chinmaya. Thank you very much. I think at the outset, I would like to thank our Murli, having brought Dr. Chinmaya to somebody is disturbing, please.
Dr. Shobha Vastrad, you may switch, mute yourself.
Dr. Chinmaya, rightly you started with a sentence, diagnosed anomaly is only a beginning. Really true. Because we as an obstetricians for our last 3 decades, we just went on doing sonography, diagnose and deliver. But after the delivery, what is happening, we never thought. I think this is the first time you have opened our eyes. After the delivery, what all will happen and how one should go ahead. I think really it's a great, and you have covered so many multidisciplinary things, which will really has given a confidence to us that think, as rightly told by that mother who wrote a letter to you, that she has become a mother rather than a woman. I think that is a very right way of telling. And you have stressed on screening history. I think that is a very important one. Quite a good number of times we busy practitioners, we don't give much importance to the screening history. I think a screening history will definitely make you to whether to operate or not to operate. And are there any other anomalies has to be looked? I think you have really stressed on that point also. And what I am very much impressed is about your smile train. Smile train at NIMS. What a wonderful the work is doing the Telangana government. I want to compliment the Telangana government having done a wonderful one. And not only that, they are doing free. what you have written there in your slide is that they are giving 1,000 rupees traveling fee. What a wonderful way of salvage this unfortunate children. And your whole talk was very comprehensive and beautiful slides covering all aspects: anatomy, physiology, operative surgery, and post-operative, everything. And what your talk has made it is a lot of hope for an anomalous baby after the therapy. We think that all anomalous babies will die at some time and they may not lead life. But your involvement with other specialities, definitely with the multidisciplinary involvement, I think has given a good eyesight to all of us. And you have stressed on planning deliveries also. Not only just giving delivery, we must counsel the parents, counsel our patients. Where is the real place where they can deliver? Just delivering at our center is not the thing. Exactly where. I think so many new things you have given us. I really, it was a great feast of knowledge, because we obstetricians always were thinking to that level. Never we went beyond the involvement with the pediatric surgeon, involvement with other people, and surgeries, and other the new things also. Really, it's a great Chinmay. Really, you have, in spite of your the bad day today, as you said, that that zeal in you to impart the knowledge was the most essential. We really appreciate that. In the absence of our Abbott executive who could not make it today, as a chief patron and organizer, I would like to thank Abbott for supporting this program. And you know that Abbott have got three wonderful curriculums. One is Dufestan, day in and day out. They were the kings for 30 years, and we never had another Dufestan for so many years. It supported the all pregnancies, including IVF. And there two other two very wonderful molecules were Femilon and Novelan. Femilon and Novelan, I remember when I was a lecturer in medical college, I started a Novelan trophy. This Novelan has so popular, and the undergraduates, postgraduates were used to be involved in that. And this is another family planning drug. Very recently, they have come out with the carbitocin injection, that is Religol. I think one of the leaders in the pharmaceutical is, and they are very much really interested in involving in academic activities. They have involved for our Cpap. I would like to thank on behalf of all of us to Abbott. Thank you, Chinmayi, once again for the wonderful talk. And it's a really pleasure that you have spent with us.
Yeah, so before we wind up, I would like to quickly read some more complimentary messages, because I want to read them. Dr. Srinivas has written wonderful talk. Dr. Usha Rani N has written excellent talk, madam. You summarized almost all anomalies in a glance. Dr. Savitri Ramesh from Madurai has written, can't forget the mother of Pradyumna. And Dr. Rajashri Paladi from Gulbarga has written, heartiest congratulations for an excellent deliberation. Chinmay, how far you are from fetal surgery? When are you planning to do?
With your blessings, maybe at some point. Right now, we do radio frequency ablations only.
Okay, so that is okay. But you know, we had wonderful talks from American speakers in Manipal. The beautiful surgeries. It is really, you know, heart stopping. Your heart stops when they are opening and then doing surgery and go push it back, baby, and then all those things. I'm sure you would do it one day. And I hand over the mic to the MC of the day, Dr. Manjula.
Thank you, Muralidhar sir, for giving such an excellent speaker for today's topic. It was really a wonderful feast to hear the knowledge from her. Now, I would like to request our treasurer, Dr. Durga Das sir, to give the vote of thanks.
Good evening, everybody. It's my privilege to give vote of thanks on behalf of Ksoga KCOGA. As rightly told by Dr. Muralidhar Pai, this is a real Cpap we had. Dr. Chinmay Rath, you have really given the Cpap to the consultants who receive the patients with the scanning report in their hand, the whole family with all lots of anxiety and hope coming to the chamber with one report of anomaly, what to do. As beautifully summarized by Dr. M.G. Hiremat, you have covered everything. Your talk was excellent. I need not say anything about that. Thank you very much for joining, spending time with us. Thanks a lot. I also thank our Chief Patron, Dr. M.G. Hiramat. More than that, I have to thank Dr. Muralidhar Pai for giving such a wonderful program, Murali. We are really happy with your selection of topics and selection of the speakers. I also thank our President, Dr. Basavaraj Sajjan, our Treasurer, Secretary, Dr. Bharati Rajshekar, the Dean of KCOGA in her absence, Dr. Hema Divakar, Secretary, Dr. Vidya Bhatt. I also thank Abbott for pharmaceuticals for sponsoring this program. I also thank John and Arun to help in conducting this program. Thank you, everybody. Stay safe, stay healthy.
Happy New Year to all of you once again.
Just let me tell you that the Davangere conference, the photos have arrived to our office. We are uploading in the website. In another 2 days, the photos will be available in the website. Please go to the website, and whichever copy you would like to have, send you that copies. And we'll be providing the photographs to all those who have received FKCOG, Fellow of Karnataka College of Obstetrician and Gynecologist, and a certificate. That time was not there to print. Now we have printed the certificate. That also will send them. And those who are participating in KCOG academic program, they will be receiving by tomorrow the attendance certificate. In future, this attendance certificate plays a very, very important role, because we have two types of membership. One is a member, another is fellow, and based on that, various activities of the KCOG are getting allied. And these members of KCOG are basically allied group of academic interest. So those who really join in the program, make their presence in the academic program, will get this membership. It is not just a general membership. Ksoga member, anybody can become by paying the Ksoga fee. But KCOG member has to be some academic interest, which we have made in our bylaws. I think our programs again are starting with a big bang, Mr. Murali, for the year 2022. Once again, I wish all of you a happy new year and a big academic program for the year, which we are already made up for the next 2 months. Thank you. Thank you very much. Good night. Namaste.
Thank you, Manjula. Manjula, I forgot to thank you. Thank you, Manjula.
Having spent with us this time, and many of those who have joined, you can just on your videos. We would like to see your face, how it is looking. Last we have seen in December, I think.
Happy New Year to everybody.
Bharati, so many. You can just make your video on, because we have got 10 minutes time for that. Yeah, you can. We have made it. We have got to the view. That is the gallery. Just you open your videos, you will be able to see. Yes, Sri Lakshmi is seen there. And Alka Kati.
Happy New Year, sir.
Andalabi, Agarwal, Sonia Malik, Vidya Tobbi, Saini Varghese, Pushpa Panikat, Murugesh, Sai Srikar.
Dr. Hiramat is taking
attendance, ma'am.
Yeah, attendance is going on.
Hi, Sri Lakshmi, missed you.
Hi, Manjula. No, I was there from the first.
Yeah, good.
I will listen to everything.
Sri Lakshmi, Dr. Chinmay, Sri Lakshmi is also a very good fetal medicine specialist.
Party for us.
Hi, sir.
Yeah. Sri Lakshmi party. When are you giving us a party?
Yes, ma'am. We will give, ma'am. I'll give. Definitely give.
Yes.
A big party.
Only looking warm and cozy.
Yeah. 5 layers. 4 to 5 degrees in the evenings.
Nice.
Oh my God.
Is it snowing, sir?
No, it doesn't snow in Gangtok, but it snows up North Sikkim.
Okay.
So now it is very easy that you can on your the laptop at 7:30 every Thursday. Which day program, which day no program. Thursday is the program. Dr. Rajeshri would like to say something.
Yeah, good evening, sir. Happy New Year to
Hi, Rajeshri.
sir, Muralidhar sir,
Happy New Year, ma'am.
Bharti ma'am, Chinmay,
Hello.
Manjula.
Hello.
Missed meeting you all in Davangere.
Hi, I said hi.
Yeah, we missed you, Rajeshri.
Yes, sir.
Yeah,
We missed celebrating our birthdays together on 19th of December.
Yes. Belated happy birthday.
Yeah, belated to you too. Chinmay, heartiest congratulations. Sir, I think from Genetic and Fetal Medicine Committee, we can have one more session on talks.
Please go ahead. You can have actually Dr. Chinmay Rata as well as Dr. Sri Lakshmi. Sri Lakshmi is also a good fetal medicine specialist.
Yes, I think
in Shimogi.
we should be planning one from the Genetic and Fetal Medicine Committee,
plan for the year.
Everything is so new about this subject that it was, I mean, till we heard Chinmay Rata about the diaphragmatic hernia, we really didn't imagine that we could give a nice baby to the couple, and so many things happening in
today it was an eye opener. It was just not learning.
Definitely, sir.
Looking beyond, that was very important.
Last year there was an IVF conceived baby with bilateral cleft lip and palate, and the couple chose to terminate in spite of doing so much of counseling that at 5th month they say we don't want to continue the pregnancy. It was an IVF conception. So many things which we need to educate, because somebody would have told them that this is going to be associated with problems, and it was the COVID times. So they didn't want to go for the genetic analysis also. And we really felt very bad that, IVF conception meant for termination.
That's what.
Many such
I would like to say last word, anything, madam, Chinmay madam. We are closing the session.
Yeah. So definitely, thank you so much for raising awareness on this topic, because like you said, like IVF couples terminating for cleft lip palate is actually somewhere it's a loss in the system. So
exactly.
Exactly.
I think, sir, education is empowerment, sir. That's what I'll say. And thank you for
thank you for giving that to us.
Yes, sir. No, sir.
Yes.
Thank you very much.
Yes.
Thank you.
Thank you,
Very
sir.
nice.
Goodbye.
Thank you.
Thank you, Chinmay. Thank you, everyone.
Thank you.
Hello, Vidya Tabbi ma'am.
Bye.
Hello. Yes. Nice. I will call you. I'll call you, Manjula. I'll call you.
Okay.
Bye to everybody. Good night. Stay safe.
Yeah. Good night, everyone.
ಓಟಿತ್ತಾ
ಓಟಿತ್ತು ಮುಗಿಸಿ ಬಂದೆ ಈಗ. Now I'm at home. ಸ್ವಲ್ಪ ಲೇಟ್ ಆಯ್ತು.
ಗೊತ್ತಾಗ್ತದೆ ಡ್ರೆಸ್ ಅಲ್ಲಿ.
ಮುಖನೂ ತೊಳೆದಿಲ್ಲ.
Anyway, you made it in time.
Yeah. Bye.
Good night all.
Good night.